I'm Matthew Banks. I'm a consultant gastroenterologist at University College London Hospital, and I'm going to talk to you today about endoscopic submucosal dissection, ESD, specifically in the stomach. And I'm going to cover the indications, detection, lesion assessment, the technique of endoscopic submucosal dissection, and a little bit about training. Now, the indications for ESD in the stomach are either early gastric cancer or visible gastric dysplasia. Now, these lesions are hard to detect, but they are inevitably present in a background of chronic atrophic gastritis. In fact, nearly all glandular gastric cancers are on the background of chronic atrophic gastritis. Once the lesion's been identified, it needs to be assessed. Now, those that can be resected curatively need to be within the expanded Japanese criteria, which are based on the likelihood of lymph node metastasis. And this includes features such as the size, histology as to whether it's well or poorly differentiated, and the presence or absence of an ulcer. Secondly, the lesion needs to be characterized by using the Paris classification. Now, there are a few papers looking at how we can accurately try and assess the depth of invasion to assess whether or not this can be resected curatively. And again, we use features such as the size of the lesion, over 30 millimeters being a poor prognostic feature, overt redness, enhanced margins. So if the margins are very raised, then the likelihood of deep invasion increases. And finally, if the surface is particularly uneven, that suggests there may be more depth of invasion. Now, once the lesion's been detected and characterized and a decision has been made as to whether it can be resected curatively, you need to plan the procedure. These are undertaken under a full general anaesthetic and can take anywhere from 30 minutes to 4 hours for the larger lesions in difficult to access places. ESD is easiest in the antrum and hardest in places like the cardia and parts of the lesser curve. Now, the kit is fairly simple. You need a cap or a distal extension on the scope, and a knife to do the cutting. My personal preference is the Erbry hybrid knife, which is a very powerful water jet that runs through the center of the knife and allows you to maintain significant submucosal elevation, and that improves your vision. The procedure involves 3 steps. Firstly, demarcating the lesion, ideally with near focus or zoom, but not absolutely. Marking around the lesion by using forced coag with the tip of the knife, and then circumferential incision, particularly in the stomach, where you cut around your markings, leaving at least a 2 or 3 millimeter margin to enable you to have an R0 resection. And finally, the submucosal dissection, which I'm not going to in detail. Once it's completely removed, pinning is really important to allow the pathologist to interpret the findings accurately, and also to orientate the lesion. Now, in terms of training, it takes many years to learn how to do ESD well. There is a European core curriculum which has now been developed, which sets out a structure for training, from understanding advanced endoscopic diagnosis and characterization of these lesions. You must have proficiency in EMR and particularly managing the complications of therapeutic endoscopy. And then they suggest you do at least 20 endoscopic submucosal dissections in animal models, of which 8 must be en bloc. And then finally, you start undertaking them on patients supervised for at least the last 10 cases, and starting in easy locations such as the antrum or the rectum. Finally, you need the ability to assess whether or not you can resect these lesions curatively.